Hello, everybody. I'm Dr. Jennifer Reynolds, and I'm the director of the Lupus Clinic at the Mary Pack Arthritis Center. And I'm happy to be able to talk for this year's virtual Lupus Society Symposium. But I'm really hoping that I can see all of your friendly, happy faces sometime soon. My talk this year is going to be about vaccines and lupus, and I'm also going to be part of the question and answer panel on Friday. So I'm hoping that you can be there as well and ask any questions that you have. Today I'm going to talk a little bit about why we give vaccines and how they work. I'm going to talk a little bit about the recommendations for vaccination in BC. And then I'm going to focus a little bit more on influenza with lupus patients, and as well as the COVID vaccines and COVID infections for lupus. So why do we vaccinate? Our immune systems are really smart, and they learn from being exposed to infections, so they're better able to clear subsequent infections, and that's called natural immunity. Vaccines take advantage of that by showing our immune system a weakened or killed version of a virus or bacteria, and then it can learn to fight that and be faster and more successful at clearing a real infection when they're exposed to it. Vaccinations have been hugely successful, and I'll show you a little bit of information about that. But it's important to remember that the older methods of vaccinating people were less precise, and newer methods are much more targeted and effective. So cowpox, I don't know if any of you knew that, they used to just give cowpox to people directly in order to give them some immunity and have them be able to fight off chickenpox. So this is a little figure that shows exactly what I said. On the left, we see that the primary immune response after being exposed to an infection takes a little bit of time, and it's only a certain amount effective. But on a subsequent exposure, and the time between this can vary from days or weeks to months or years. But when exposed to another antigen load, our immune system responds much faster and much larger or much stronger to the secondary exposure. So how do the vaccines do this? This is an example of one part of our immune system that most of you have probably heard about, and that's antibodies, because antibodies play a huge role in lupus as well as in fighting off infections. So in this figure, this is someone's blood, and they've got antibodies against measles, against influenza, against chickenpox, because they've either seen them or they've been vaccinated against them. But in green is a new pathogen. It's something they haven't seen before, and so they don't have any antibodies to that. A vaccine can help by providing a little bit of the organism that's new. So in this picture, they're showing it as the outside wall with a little bit of that marker protein. And that's enough for our immune systems to make an antibody against this organism, and then they're able to kill it and clear it much more quickly. So this is an old example of the effect of vaccines. So you can see that in Canada between 1924 and about 1954 along the bottom, there was a varying number of measles infections, but overall there was probably about 50,000 infections a year. In 1963, the first vaccines were introduced, and over the next few years there was quite a significant uptake, so that by 1974 the numbers had dropped markedly, and they continued to drop into the 90s. The green arrow shows when the second dose and the catch-up schedule was introduced in Canada, and you can see that that resulted in a further decline. So much so that on this scale, you can't really see what's happening in the 2000s. So the little insert shows you that, now the scale on the side is from 0 to 1,000 instead of 100,000, because this is the numbers we're looking at. And you can still see there's small outbreaks of measles, but overall, the benefit from the vaccine is persisting. So currently the BC CDC is responsible for making recommendations for who should be vaccinated and when. They have quite an extensive schedule for babies because they don't have any natural immunity to things. Babies do get antibodies from their mother that cross the placenta as well as through breast milk. But as their immune system develops, they're given vaccines so that they can fight off infections and that they don't get sick. Those recommended vaccines gradually build through high school, and then they kind of stop. As adults, we're expected to have a mature immune system, and the only real recommendations are for tetanus and diphtheria every 10 years. There's a new recommendation for tetanus diphtheria with pertussis in pregnancy. And then there's different recommendations if you're going to travel outside of Canada, or if there's outbreaks like COVID, then there's additional vaccines recommended. There's no general recommendation for the influenza vaccine, but a lot of patients end up being recommended to get it because they're either a close contact or they themselves are immunocompromised. So that's the third category that BC-CDC talks about. And seniors tend to have a decreased effectiveness of their immune system, so additional vaccines are recommended, and immunocompromised patients, either through illness or medications, are at increased risk of infections, and again, additional vaccines are recommended. So there's 2 different vaccines for pneumonia that are recommended, as well as the yearly influenza vaccine. Interestingly, BC-CDC does recommend the Shingrix or shingles vaccine for patients over 50, but there's actually no funding for this, so that's a self-pay vaccination. This didn't transfer well, but it's not that important what the list of vaccines are on the left. I was just trying to show you the strict timelines that are recommended and the number of vaccines. So that vaccine, the very first one, is actually 5 different antigens put together in one vaccine, and that's given to infants at 2, 4, and 6 months. And then there's various boosters through time. There's at 1 year, the infants have a mature enough immune system that they can now get the measles, mumps, and rubella vaccine, and then there's a couple of boosters for that as well. So a lot of these vaccines have been so effective that we really don't see much of the original infections. So tetanus, we've heard about it, but I don't think very many people ever get to see it. And that's a good thing because it's quite a severe illness. It's caused by a bacteria that enters the body through breaks in the skin. And the symptoms are painful muscle spasms, breathing problems, and it can progress to paralysis and potentially death. Diphtheria, another one I've never seen. It's a disease that causes a thick coating in the back of the nose or throat, making it difficult to breathe and swallow. It can also attack the heart and the nerves. Pertussis or whooping cough is highly contagious and is actually prevalent in the community. It causes prolonged distinct coughing, which can be quite disabling or disruptive for patients, though it doesn't tend to be as lethal. So what about lupus patients? Because that's why we're here today. So we know that having lupus increases the risk of infections. The changes in the immune system that bring on autoimmunity and make your immune system attack you can also decrease its effectiveness at clearing certain vaccine or certain infections. 2 examples that I put up here are human papillomavirus or HPV. So we see an increased risk of cervical cancer in lupus patients, and it's really important to be screened for that. Another one that's really common is herpes zoster or shingles, and we see that much more frequently in our lupus patients than even in other autoimmune diseases. The other important interaction is that getting an infection can also trigger a flare of your lupus. So the biggest study I found just recently came from Korea with almost 25,000 patients with lupus, so just a huge number of patients, and they showed that there was a significant increase in lupus flares that were severe enough to cause hospitalization that occurred within 7 days of an influenza infection. So certainly not everyone, but a certain proportion of people will have a flare after influenza, and it can be quite severe. So what is influenza? It's another virus that varies in terms of its severity and the amount of spread year to year. It tends to occur in what we call the respiratory season, so through the fall and winter when Canadians tend to be inside more. That's much more problematic in seniors and actually causes quite a lot of mortality or death. There's many virus strains, and they vary year to year in terms of which is more prevalent. The flu vaccine can decrease both the severity of illness and the risk of death, and it also makes it harder to spread that to other people. Many different pharmaceutical companies make different vaccines, and Canada purchases a set number each year. Only the nasal spray contains live or attenuated virus, so it would be possible to get the flu from that nasal spray, and it's not recommended for anyone with an autoimmune condition, but it's generally recommended only for children anyway. None of the injectable vaccines contain any live virus. The number of strains and the with or without adjuvant vary by company and vaccine. The adjuvants are additives to the vaccine that irritate or stir up the immune system and increase the response to the vaccine, but they can also have a side effect of increasing the immune activity generally. So, if you don't need them, it's better to not have one. The success of the companies in picking the strains to include in their in their vaccine, as well as just the severity or the effectiveness of the actual vaccines, varies year to year. Fortunately, but not for good reason, influenza in Canada in the last couple of years with COVID has been a really much decreased in its number of cases. So this year there were vaccines with 3 strains of influenza that were approved, but none of them ended up being marketed in Canada, except there was one exception. There was a adjuvant containing vaccine that was available for seniors. And then there was multiple vaccines with 4 strains that were approved and recommended. And most times the pharmacy would have one of those and you wouldn't even know which one was available for you. They're very similar year to year. There's a monitoring system that looks at levels of influenza across Canada week by week, and really low levels of influenza have been seen in Canada so far this fall and winter because of our restrictions with COVID. So that's another segue into coronavirus 19 or COVID. That was a new virus that hadn't been seen before, so nobody had any antibodies to it. It started in December or so of 2019, and it became obvious right from the get-go that there would be a potential increased risk for patients with immunodeficiencies or being on immunosuppressing medications. There was concern about more severe infections, higher rate of hospitalizations, and higher death rates. So very early on, rheumatologists created a worldwide database of rheumatology patients who tested positive for COVID infection. It was called the COVID-19 Global Rheumatology Alliance, and information was collected about the rheumatic disease, other health conditions, medications, and the severity of COVID-19. There was no information about the patient's name or date of birth or anything that could identify the patients, and it was self-report by the rheumatologists. So around Vancouver, several of the rheumatologists were very active in putting in patients, including me. So early information that came out from this had a whole variety of autoimmune diseases, but because lupus is less common, there was less patients with lupus. So this is just all of the patients enrolled in that database, and what you see at the top in blue are risk factors that are other comorbidities or other conditions that patients would also have. In purple in the middle section is the medications that patients were taking, except for the green at the bottom, which was the steroids, because they're so important in terms of infection risk. So in terms of the comorbidities, these are things that you might have heard about. So we know that age has always been a risk factor, and we certainly saw higher risk of death and higher risk of more severe disease for patients who are over 65, for patients who had hypertension or cardiovascular disease, patients who had underlying lung disease or diabetes, chronic renal insufficiency, or end-stage renal disease. In purple, the top little purple dot is the patients who weren't on any disease-modifying or immunosuppressive medications. The next line down are the traditional DMARDs that we use, things like methotrexate or azathioprine, and there was a suggestion that there was some increased risk, though it wasn't as important as the factors above. Interestingly, in this very early data, it looked like the biologics, including anti-TNFs, were protective, that there was less risk for patients on those medications, and it wasn't clear why that was, and truthfully, it hasn't really borne out with subsequent data. At the bottom is the steroids. So early on, it looked like it made a huge difference if you were on more than 10 milligrams a day. So the top dot is the patients that weren't on any steroids. The next line down, just a smidgen of an increased risk, were patients on 1 to 9 milligrams, but once they were up to 10 or more, there was certainly a doubling of their risk. So what about since then? So just recently in February, there's been a publication about the lupus patients in particular from this database. And it's showing some similarities and some new things. So again, we see that being older is an increased risk for worse outcomes. Male patients actually did worse, and we see this frequently in a variety of lupus settings. The prednisone story became a little bit more confusing, as it seemed like any prednisone at all is associated with an increased risk of poorer outcomes, not necessarily worse on higher doses, which doesn't make a huge amount of sense. Comorbidities are important, so chronic kidney disease came out as a really important risk factor, as well as heart disease and high blood pressure. Interestingly, they were able to show that patients with moderate or high disease activity from their lupus actually had a higher risk. And then there was increased risks associated with rituximab, cyclophosphamide, and mycophenolate. It was harder to put a number on those because there weren't as many patients. So we have, through the database and through some other studies that I haven't presented, we know that there is some increased risk for lupus patients. A lot of that risk is explained by the medications that they're taking or by their other comorbidities or other medical conditions. So what about vaccinations? So there's really good evidence that vaccines are really effective in the general population, with a strong drop-off in hospitalizations and deaths as the vaccination programs rolled out. In the general population, there was a very small risk of blood clots. It's not the same as the risk of blood clots that lupus patients get, which are autoimmune. It's more of an allergic type reaction. But you always have to remember that 20% of patients that get a COVID-19 infection develop blood clots, so a really high number of infected patients, and all patients that are admitted to the hospital. So if their disease is severe enough, they get started on blood thinners. So with the marked drop in the risk of hospitalization, you still have a marked decrease in your risk of blood clotting, but there is that small risk of blood clots. There was also some allergic reactions, but again, this was very low risk. But given the numbers of people that were being vaccinated, it was certainly seen. And anybody who's got a known allergy to the components of the vaccines, they've recommended not be vaccinated. So that's in the general population. What about in lupus patients? So the effectiveness, the ability of your body's immune system to respond to a vaccine varies depending on the medications as well. Unfortunately, rituximab, Benlysta, and mycophenolate all work by decreasing that same pathway which is responsible for lupus symptoms, and so all of them decrease the response to vaccines. None of them 100% shut it down, so people still make some antibodies, but generally not as many as if they're not on those medications. There's some benefit with timing of vaccinations and the timing of the medications, particularly for rituximab, which is only given every 6 months, and that can improve response. And The duration of antibody response is still being studied. We've seen in the general population that it falls off around 6 months, but there's less data in terms of what happens in lupus patients or in other autoimmune diseases. There's an ongoing Canadian trial that's measuring that in patients with rheumatoid arthritis, with ankylosing spondylitis, with psoriatic arthritis, as well as in lupus. And so over time, we'll be able to see that going forward. There is a small risk of a lupus flare in lupus patients getting vaccinated, but these are much less than 5% of patients, and the flares tend to be quite mild. I've only had a couple of patients who've needed short courses of prednisone for that. People ask me about which type of vaccine they should get, and either Pfizer or Moderna were seen to have a stronger response or more effective at preventing infection. So these were recommended for immunocompromised patients to give them the best chance of having a good response. Consequently, the other vaccines are less studied in immunocompromised patients, and it's hard to recommend them. In general, in BC, only the Pfizer and Moderna ones were being offered. So what about the additional dose? If we know that lupus patients might not be making as many antibodies, can we do anything to improve that response? And the initial data came from a study in cancer patients where they measured the immune response to the 2 vaccinations and showed that only about 20% of the cancer patients had an adequate response after 2 doses, but that was boosted over 50% after a 3rd dose. And based on that, BC actually approved a 3rd dose for anybody at risk for poor response to the first 2 vaccines. We generally don't measure antibody levels because the absolute number that you need isn't totally clear. But because there's an expected lower level of response, having that 3rd booster, or 3rd dose rather, can improve the likelihood of response. Interestingly, because the 3 vaccines were considered to be equivalent to 2 in the general population, they were considered the first course. And now patients who've had that first course are being offered a booster as well. And so I'm going to talk a bit about boosters. So we know that antibodies, or those proteins, are made by long-lived plasma cells. And in most natural infections, those plasma cells are around for years and years after an infection. But in COVID-19, the antibodies that we make after a natural infection seem to disappear relatively quickly, that we're not protected down the road. So antibodies from vaccinations do seem to last longer. So even with, if you had somebody who got infected at the same time as someone else got a vaccine and then checked 6 months later, the person who had the vaccine would have more antibodies, which is not typical for most infections. But they still do decline over time. And when they looked at rates of infection and the time since vaccination, it seemed to show some loss of benefit around 6 months. So a booster dose was recommended. This varies, so some of the data that you might see talked about from the US was with the first 2 doses closer together, and that made a difference in how long the antibodies lasted. But in BC, it seems like a booster around 6 months is about the timeline for when you're starting to lose benefit. And so that's been recommended for everyone. And now they're trying to catch up with the boosters for the people who had 3 doses for their initial course. So what's next? We do expect that there'll be some waning of benefit from the vaccines. We have that in our other vaccinations that I talked about at the beginning. So hepatitis B, for example, requires 3 doses, and then we have sustained antibodies. And a booster isn't recommended unless you don't respond. Shingrix requires 2 doses and then has a sustained benefit, but it actually hasn't been out for long enough to know, and we potentially may need booster shots for that one. Pneumovax is recommended as a single dose, but the benefit declines over years. And depending where you are, a booster is recommended at 5 to 10 years. Tetanus, you could see that we're always recommended every 10 years to get a booster, and that's despite multiple doses as infants. So it's not something that tends to stick around indefinitely. My guesses, and this is guesses, this is not science, is that because of the kind of virus coronavirus 19 is, that we're likely to have ongoing mutations in the virus and ongoing infections in the population. There will be mutations that come through, some of which aren't as strong, so they don't tend to propagate. But some of them are likely to be more infectious and spread quickly, and I think we're seeing that recently with the BA2 variant of Omicron. And some mutations cause more severe illness, and I think we saw that with the Delta variant that was more prevalent in the fall. So virus mutations also tend to be more created and spread in areas of low immunity, so either low natural infection or low vaccination rates. So I think that it's imperative that we try and get vaccines accessible to other parts of the world where they haven't been, even from a selfish viewpoint, that it'll decrease our risk going forward. It is possible that some of the future mutations will be immune, or that the vaccines won't work as well for them, and we'll need to have an updated or a newer version of the vaccine to get additional benefit. But it's less effective as opposed to not effective at all. And so we'll always have some immunity from our current vaccines. So in summary, everything I've talked about in 20 minutes, lupus patients are generally at increased risk for infections, particularly viruses. Immunosuppressive medications can increase the risk of infection on top of that. Immunosuppressive medications can also decrease the response to vaccines. And it's important to adjust medications to improve that vaccine response, and you should talk to your rheumatologist about that. Vaccinations are safe for lupus patients as long as they're those killed viruses and not the live ones, though there would be a very small risk of mild flares, and that vaccinations are likely to be an ongoing recommendation through the future. That's it for me. I'm happy to answer questions on Friday, and I'm looking forward to seeing you all in person in the future.